Hello, everyone. Welcome to tonight's webinar. My name is David Bamshad, and I'm a member of the Vascular Disease Service Line. On behalf of the Society of Interventional Radiology Resident Fellow Student Section, thank you for taking your time tonight to hear the webinar on peripheral artery disease. Before we begin our session, I want to remind everyone that this webinar will be recorded and will be available on YouTube by searching IR Education. Feel free to ask questions at any time. You can enter them into the chat box on your GoToWebinar control panel. We'll keep a track of them and answer them at the end. Also, please check the RFS website regularly for upcoming events and follow us on Twitter and Facebook for other updates and posting of clinical material. It's my pleasure to now introduce our speaker for tonight, Dr. Arash Gohari. Dr. Gohari is a member of Society of Interventional Radiology and the Radiologic Society of North America. He received his medical degree from Albert Einstein College of Medicine. He completed his radiology residency at Montefiore Medical Center and completed cardiothoracic imaging and interventional radiology fellowships as well. Dr. Gohari's clinical practice and research focus on various aspects of cardiac and thoracic imaging in addition to vascular and interventional radiology. Thank you, Dr. Gohari, for taking your time tonight to talk to us tonight about peripheral artery disease. So we can get started now.
Thank you, Dr. Bamshad. It's a special privilege to be presenting in this forum. So tonight I will be discussing peripheral vascular disease and focus on peripheral arterial disease. As you all know, peripheral arterial disease is a very common condition and it has the potential to cause loss of limb or even loss of life. It usually presents with symptoms of insufficient tissue perfusion, and is usually likely initiated by existing atherosclerotic disease, which can be acutely compounded by either emboli or thrombotic disease. I'm sure many of you know many people that live daily lives with significant degree of peripheral arterial disease. However, in settings such as acute limb ischemia, peripheral arterial disease can suddenly become life-threatening, and it might necessitate emergency intervention or even surgeries in order to minimize morbidity and mortality. So tonight, we're going to have a few objectives for the webinar. Our number one objective is delineate the basic anatomy of the lower extremity arteries. Second objective will be describe the pathophysiology, risk factors, and prognosis of lower extremity peripheral arterial disease. The third objective will be describe evaluation of patients with peripheral vascular disease and pertinent non-invasive diagnosis, which is big part of the patient's workup. And finally, we will review different and various peripheral arterial disease treatments, and we will discuss including their indications and complications. So let's start with a brief anatomy of the lower extremities. The arterial supply of the lower extremities is via the iliac arteries, which are the terminal branches of the abdominal aorta. Common femoral arteries, which are direct continuation of the external iliac arteries, they begin at the level of the inguinal ligaments, and they divide into the profunda femoris and superficial femoral arteries. As you can see in this posterior image, the posterior view, the popliteal artery, is the direct continuation of the superficial femoral artery in the adductor canal. The popliteal artery terminates into two branches, anterior tibial artery and the tibioperoneal trunk. The anterior tibial artery then passes down through the interosseous membrane, the lateral aspect of the leg in the anterior compartment, and it continues to the dorsum of the foot as the dorsalis pedis artery. The tibioperoneal trunk divides into the posterior tibial and peroneal arteries. The posterior tibial artery passes downward and behind the medial malleolus, and it divides into medial and lateral plantar arteries, as you can see on these images. Next, we will discuss the pathophysiology and risk factors for peripheral arterial disease. Peripheral arterial disease is primarily a result of atherosclerosis. Atherosclerotic process usually it's a gradual process and eventually can lead to complete occlusion of the medium and large arteries. The disease is typically segmental and has a significant variation from patient to patient. Risk factors for peripheral arterial disease include smoking, hyperlipidemia, diabetes, and hypercoagulable states. Of course, other etiologies that can contribute to peripheral arterial disease progression, they include inflammatory processes such as autoimmune disease, including vasculitis, arthritis. One important factor to keep in mind is radiation-induced peripheral arterial disease, which is becoming much more common and should not be overlooked. And it's the typical schematic images of atherosclerotic disease. On the first row, you can see there's normal arteries, and the second row, you can see a buildup of atherosclerotic plaque and eventual narrowing with gradual stenosis of the underlying arteries, which is caused by the cholesterol plaques. Prognosis. So what is the prognosis of patients with peripheral arterial disease? Usually other conditions coexist with peripheral arterial disease, and they include coronary artery disease, atrial fibrillation, cerebrovascular disease, and renal disease. Peripheral arterial disease that coexists with coronary arteries is a significant problem for many physicians which need to treat the patients. In this first study, which you can see by Hussein, they demonstrated that peripheral arterial disease that coexists with coronary artery disease indicates increased burden of atheroma, and that's associated with increased morbidity and mortality. In the second study by Nakata, in this study they suggested that even asymptomatic peripheral arterial disease is associated with increased coronary arteries mortality. And the third study which I found, recent study, which is very significant, that female sex appears to have an effect on outcomes after lower extremity interventions for peripheral arterial disease. In this retrospective study, evaluating close to 12,000 patients, female sex was associated with a higher rate of vascular complications, transfusions, and embolism, but there were no significant differences for inpatient mortality, MIs, stroke, or TIAs. So how do we evaluate a patient with peripheral arterial disease? Peripheral arterial disease is rarely acute on onset. It usually manifests a more chronic progression of symptoms. Intermediate claudication may be the only manifestation of early symptomatic peripheral arterial disease. And you should keep in mind that the site of occlusion and presence of collateral circulation usually determine the severity of the symptoms. The level of arterial compromise and anatomical location of the claudication are closely related. For example, if the patient has femoral popliteal disease, they will manifest as pain in the calf. Symptoms are usually precipitated by walking a predictable distance. Usually patients know that beyond a certain amount they will get these signs and symptoms. Symptoms are usually relieved by rest, and of course over time collateral circulation will develop and reducing the symptoms of intermittent claudication. Claudication may also present as a sign of hip or leg. Patients that they feel like the leg giving out after a certain distance of walking, and they may not demonstrate the clinical and typical symptoms of pain on exertion, which we all are used to thinking. The pain of claudication usually does not occur with sitting or standing, rather is more with walking. And we should keep in mind the patient's medications may provide a clue to the coexistence or existence of a PVD. So, physical examination, a systematic examination of the peripheral vasculature is critical for proper evaluation of these patients with peripheral arterial disease. Peripheral signs of peripheral vascular disease are the classic 5Ps, which include pulselessness, paralysis, paresthesias, pain, and pallor. And it's very important to realize that paralysis and paresthesia suggest limb-threatening ischemia, and they require immediate intervention. We should assess the patient for any heart murmurs and other abnormalities of the pulse or bruise. All the peripheral pulses should be examined very carefully for pulse quality and presence of any bruit. As a side point, which is very important to keep in mind, which I learned later in my career, the dorsalis pedis artery is absent in 5 to 8% of normal subjects, but the posterior tibial pulse is usually present. Both pulses are absent in less than 0.5% of the patients. On physical examination, you can see that the skin may have an atrophic, shiny appearance, including alopecia, dry, scaly, erythematous skin with chronic pigmentation and changes. Non-healing ulcers in the lower extremities also suggest peripheral arterial disease. So what sort of a laboratory studies do we need for these patients? Routine blood tests are usually indicated for evaluation of these patients, especially the ones that have serious compromise of the vascular flow to the extremities. And this routine test they include CBC, BUN, creatinine, and electrolyte, so that it can help us evaluate for signs of in-organ injury and for factors that may lead to worsening of peripheral perfusions. Keep in mind that elevated levels of inflammatory blood markers such as D-dimers, C-reactive proteins, IL-6, and homocysteine have also been linked to the lower extremity for tolerance of exercise. And of course, this test should be done as an outpatient, and there's no need for immediate imaging. So imaging studies. So what sort of imaging studies do we need? Non-invasive tests for vascular disease include ankle brachial index, better known as ABI, CT, MRI, and contrast angiography. Imaging plays a very crucial part because delay associated with obtaining proper diagnostic tests in the setting of limb ischemia can delay definitive treatment and lead to bad outcome. Let me see what happened here. Oh, I pressed the wrong button. Sorry. So next is the most common test performed is usually ABI. ABI can be performed at patient's bedside and with the patient in supine position. Pressures are measured with Doppler ultrasound at the brachial artery and the posterior tibialis artery. The ankle systolic pressure is divided by the brachial pressure. Blood pressure is usually normally slightly higher in the lower extremities than the upper extremities. It's very important to compare both the contralateral side because it may suggest degree of acuity of the ischemia. Normally, the ratio of the ABI is less than 1. In a severe peripheral arterial disease, it is less than 0.05. ABI of less than 0.9 has a sensitivity of 90% and a specificity of 98% for detecting lower extremity stenosis for greater than 50% of the patients. An ABI less than 0.9 suggests a need for further vascular imaging. Angiography in a stable patient would be great. And operative exploration in an unstable patient is a must. An ABI greater than 0.9 decrease the likelihood of any arterial disease. Thus, the patient may be observed. So other imaging studies that we do, Doppler ultrasound, they are very useful in determining the flow status. Lower extremities are usually evaluated over the femoral, popliteal, dorsalis pedis, and posterior tibial arteries. The presence of distal flow, of course, does not exclude emboli or thrombi because collateral circulation may be the sole source of distal flow. It's very important to realize that plain films are of very little use in the setting of acute peripheral arterial disease. And of course, diagnostic arteriography is gold standard, however, is risky and predominantly has been replaced by CT and MRI. And although non-contrast CTs can be useful for imaging of calcification and atherosclerosis, contrast studies are the most useful for imaging arterial insufficiency. Renal function should be obtained and determined before contrast administration. Peripheral arterial disease, of course, usually coexists with risk factor for contrast-induced nephropathy. And CT studies in patients who exhibit symptoms of PVD can be of great benefit in treatment decision and treatment planning. And benefits of CTA, CT angiogram, include rapid non-invasive imaging and wide availability. Almost every ER in the country, they do have a CT scanner that can perform a CTA. And disadvantages of the CTA, they include exposure to iodinated contrast and ionizing radiation. EKG can be helpful to show if the patient is normal sinus rhythm or the patient has some sort of dysrhythmia or AFib. So this is a typical picture of a patient with extensive peripheral arterial disease. You can see some significant multifocal narrowing. It is crucial to differentiate the thrombotic versus embolic conditions because both can present with acute limb ischemia signs. In thrombotic state patient, the patient usually has a history of claudication, peripheral arterial disease, and bypass graft. In thrombotic patient, on physical examination, usually there is a hair loss, shiny skin, and bilateral disease. Patient has a history of previous angiography with diffuse disease and multifocal complete or incomplete vessel occlusions. In contrast, embolic situation, patient has a history of cardiac events, acute onset, and history of emboli. Physical examination, patient has a normal contralateral exam. Patient might have AFib. And as it shows on this image, on angiography, there's a meniscus and abrupt cutoff of the normal vessel. Usually bifurcations are affected. And sometimes it can be difficult to determine the exact etiology. You can have both. And the exact etiology can be determined in approximately 85% of the patients. In this recent study, the main finding shows that the 100% calcified occlusions of the superficial femoral artery and popliteal artery region were approximately 9 times more likely to be associated with technical failure compared with the lesser extent of calcification when the doctor, the surgeon, or the IR doctor, they were using basic catheter and wire endovascular technique. As I mentioned earlier, risk factors for development of vessel calcification, they include diabetes and chronic renal disease. The authors of this paper, they noted that CTA scans are useful for a variety of reasons, including treatment planning. And furthermore, preoperative CT angiograms can influence the providers to opt out of an endovascular approach and proceed directly to a bypass in the case of severe disease. So CTAs are becoming the routine for evaluation of patients with peripheral arterial disease, especially in the acute setting. So how do we manage patients with peripheral arterial disease? The management of patient peripheral arterial disease is very complex and includes modifications of the risk factors. We need to consider different pharmacological therapies, start the patient on supervised exercise therapy, and even possibly surgery. Conservative management with analgesia, antiplatelet, statins, and even primary amputation might sometimes be appropriate for the patients. Lower extremity arterial disease has historically been classified into three broad clinical categories, as you can see on this slide. Patients who have an ABI less than 0.9 but are completely asymptomatic. Intermittent claudication and chronic limb ischemia are based on distinctly different presentations, natural history, associated morbidity and mortality, and they respond differently to different treatments. Patients with asymptomatic peripheral arterial disease and those with intermittent claudications have a significantly different course than patients with chronic limb ischemia. Peripheral arterial disease that is asymptomatic often remains so indefinitely, and symptoms of intermittent claudication may worsen over time, but progression to rest pain or tissue loss is very unusual. Factors that increase the likelihood of progression are the risk factor, especially smoking and diabetes. We describe claudication as fatigue, aching, or burning in a muscle group that is caused by it's caused by transient ischemia, and usually it is exacerbated by exercise and relieved by rest. Chronic limb ischemia is ischemia at rest that is persistent and recurring, and patients can be dependent on opiate analgesia. And the treatment of chronic limb ischemia versus asymptomatic PAD and intermittent claudication is very different. So, what is the goal of therapy? The goal of therapy in patients with peripheral arterial disease is improvement in symptoms and quality of life. And for patients with chronic limb ischemia, the goal of therapy is pain control, wound healing, and preservation of the functional limb. Initial treatment for peripheral arterial disease is cardiovascular risk modification and antiplatelet therapy to reduce the risk associated with cardiovascular and cerebrovascular complications and improve patient survival. These include smoking cessation, glycemic control in diabetic patients, blood pressure control in hypertensive, statin therapy, and antiplatelet therapy. The therapeutic recommendations include single agent antiplatelet agent for prevention of cardiovascular disease. And this medication should be used in combination with efforts to reduce risk factors, again, including smoking cessation and regular exercise. Statins, of course, have been shown to improve prognosis, but they lack immediate effect. Exercise therapy is extremely effective and recommended as the initial treatment for all patients with intermittent claudication. And of course, the exercise has to be supervised and has to be at least greater than 30. Should be at least 30 minutes and more than 3 times a week in order to see the effect. As far as medications that are given, silastazole, which is a phosphodiesterase 3 inhibitor, it increases walking up to 50% and can improve quality of life scores. The second line treatment is pentoxifylline, which is second line and can improve 12% in walking distance. What if the initial treatments fail or don't work and patient is still symptomatic? When conservative measures fail, revascularization procedures are reconsidered. However, the timing and the need for revascularization depends on patient's presentation, if it's acute or chronic. My major concern usually for intervention in patients with claudication is that sometimes patients may suffer complications that worsen their symptoms after intervention. And although the presence of PAD and its severity is an important marker for cardiovascular disease, symptoms of intermittent claudication are associated with only a small risk of progression to limb-threatening and lower extremity ischemia or amputation. In-stent stenosis, stem fracture, vessel thrombosis, infection, and embolization are complications of interventions that can have associated risk of developing limb-threatening ischemia. So therefore, if patient has asymptomatic PAD or just intermittent claudications, the physician should really consider what is the best intervention for that patient. Revascularization management of arterial occlusive disease are usually grouped into two major groups: open reconstruction, bypass, and endovascular therapies. Multiple factors determine which approach is most beneficial for a given patient, and a comprehensive understanding of patient's needs and goals are essential. So which approach do we choose? The Transatlantic Intersociety Consensus, better known as a task working group, classified PADs based on anatomical locations into aortoiliac, femoral-popliteal, or infrapopliteal segments, and also based on the severity of the disease, type A, type B, type C, or type D, as you can see on these images. Recommendations for an open or endovascular approach are based on the likelihood of therapeutic success, and endovascular therapy is usually preferred for type A/B lesions. However, when open revascularization are recommended for type C or type D lesions. For type B/C lesions, endovascular and open therapy are both acceptable depending on patient's surgical risk and the physician's preference, and of course the expected durability of the intervention. Any questions thus far? So what are the techniques that we use for percutaneous revascularization? The most well-known technique is subintimal angioplasty, which is a technique by which a wire is advanced through the intima of the blood vessel beyond the vascular occlusion. By doing so, the occlusion is crossed and is amenable to different treatments you can do, such as angioplasty or stent placement. So this is subintimal angioplasty. It's very commonly performed on a day regular basis for treatment of patients with peripheral arterial disease. Other tool, very common tool for percutaneous revascularization is angioplasty. Balloon angioplasty in the femoral popliteal segment has a very high rate of reocclusion and restenosis. There are a different number of different medical therapies which are designed to prevent restenosis, and one of them is paclitaxel, which has been shown to improve the outcomes. A local delivery of the paclitaxel was initially studied in the coronary artery disease and subsequently has been used for PADs in the extremities. Another tool that we use is are the stents. We have the stents are usually divided into covered or non-covered stents. Some stents are heparin-bonded stents. Stent grafts are stents which are covered by a fabric and may be more resistant to neointimal hyperplasia and stent fracture. And it's hypothesized that the addition of heparin to the surface of the stent graft may have an additive antiproliferative effect. However, a lot of physicians, they're concerned that there are different modes of failure for this patient, and the modes of failure are not the same as bare metal stents. So you can see here we got bare metal stents and stents which is graft and heparin bonded. And most recently, we have drug-eluting stents and biodegradable stents, which are becoming more and more popular. Moving on, atherectomy, which is basically cuts down, and we got two different types of atherectomies. We got directional atherectomy and laser atherectomy. Basically, is like a drill which goes through the occluded vessel, and afterward, the patient can have angioplasty or a stent placed. And then, as far as being one of the latest, cryoplasty, which is an alternative to angioplasty, is a technique that, in theory, can reduce recoil, dissection, and intimal hyperplasia by applying a very cold temperature directly to the vessel using a cryoballoon. The cryoballoon can be used as a primary angioplasty balloon or in conjunction with a stent. So in this recent study, which was very recently published by Kaufman and Lipinski, for the outcomes of both restenosis and target limb revascularization, the majority of therapies showed superiority when compared to just balloon angioplasty. Bypass reached a statistical significant superiority over bare metal stents and balloon angioplasty for restenosis, but not target limb revascularization. The highest rank therapy for restenosis was bypass surgery, followed by drug-eluting stents and drug-coated balloons, then followed by covered stents, bare metal stents, and PTA. When comparing restenosis at 1 year to eliminate follow-up time bias, the results again showed superiority of all treatment modalities over PTAs. So many years ago, 10, 15 years ago, a lot of people used to just balloon angioplasty, and this study shows that a lot of other modalities, they are superior to just balloon angioplasty. So the conclusion of their study was treatment of femoral popliteal disease has significantly evolved in recent years with higher rates of patency and freedom from TLR. However, the utility of these treatment strategies in terms of reduction of amputation and overall survival remains in question, because in this study they did not use atherectomy devices. One more thing that's very significant, they say medicine is very regional. In the study that was done in this paper by Soden, it shows that medicine is can be in different part of the country can do medicine differently. In the conclusion, in this real-world comparison among VQI regions, we found significant variation in perioperative and 1-year endpoints of patients' PAD going under bypass endovascular intervention. And again, significant variation between regions exists in outcomes after revascularization for peripheral arterial disease, and it should prompt further research into appropriate patient and treatment selection. So moving on to complications. Complications from percutaneous angioplasty requiring some form of treatment occur in 1 to 4% of the published cases. Complication rates are higher, usually with longer lesions. Local complications related to arterial access, they include groin hematoma, which is 2 to 4%, pseudoaneurysm, which actually I treated one of them today, they are 0.3 to 2%, and arteriovenous fistula are much rarer, and actually I've never seen one personally. They are 0.1 to 0.3%. Complications related to catheter manipulation, angioplasty, and stenting include distal embolization, which is 2%, thrombotic occlusion, which is 2%, and rarely arterial rupture. Femoral popliteal stents can fracture, possibly due to dynamic forces of the knee and the hips. The risk for stent fracture increases with treatment of longer lesion and multiple stent deployments. Stent fracture is associated with increased risk of stenosis and late occlusions. Again, the complication, we got access site, which can be immediate, site of intervention, immediate between 30 days to 2 years, and after 2 years. Peripheral arterial treatment goals. We try to prevent MIs, stroke, and cardiovascular death, and improve symptoms to preserve the patient's limbs. The goal of the treatment of patients with peripheral arterial disease is threefold. Again, to prevent the MI, stroke, and cardiovascular death, and improve the symptoms and to prevent limb. Both optimal medical therapy and revascularization techniques, they have dramatically improved over the past quarter century. Smoking cessation and treatment of hypertension, hyperlipidemia, and diabetes, they reduce risk of cardiovascular event in all patients with peripheral arterial disease. In addition, the use of antiplatelet therapy is also very important in reducing risk of MI, stroke, or cardiovascular death. Revascularization can be performed percutaneously in many settings, although, as we discussed, certain clinical scenarios require first-line surgical approach. Chronic limb ischemia requires revascularization with the goal of achieving straight line blood flow to the foot. Intermittent claudication is caused by infrainguinal disease and is treated initially with, as we discussed, elastazole and exercise therapy. Revascularization for intermittent claudication is performed most often percutaneously when symptoms persist. Percutaneous revascularization is an initial treatment strategy in isolated iliac artery stenosis because of the excellent procedural outcome and long-term patency. Drug-eluting stents, as we discussed in that last study, might offer low rates of restenosis, but further research and cost analysis are necessary to define their role. Further studies for evaluation of the stents and other devices such as atherectomy devices and cryoplasty and techniques should be performed to demonstrate not only patency of vessel but also show that there is long-term outcome which improve limb salvage, especially in patients with chronic limb ischemia. Improved walking and level of exertion and distance also important. And the most important, of course, is improved quality of life for all our patients. At the end of the day, it's very important for us to realize that we do not want to be in a situation to say that the operation was a success, but the patient died. So we should look at the patient as a whole and see what benefits the patients the most. Any questions?
Thank you very much, Dr. Gohari. That was a great talk. If anyone has any questions, feel free to type them in the question box. In the meantime, a question that I had was with regards to the laser atherectomy or the cryoplasty. Are these often performed like at your institution, or most of the times it's just angioplasty?
Most of the time, which one? Cryoplast? What were your cryoplasty? I haven't used. What was the other?
Cryoplasty and laser atherectomy.
No, laser atherectomy. We do the laser atherectomy. Laser atherectomy is pretty atherectomy, not laser. Atherectomy device that we usually do use, but laser atherectomy. In my practice, I do not use laser atherectomy, but I know people that use them routinely.
Okay, cool. And then also like between angioplasty and stents, is it just a preference or is there like a protocol?
No, usually it's based on this study. Usually depending on the task lesions also and where you are and the long-term patency that you're looking at. So usually, my practice, we do primary stenting. That's what we do for most of the times.
All right. Great. If anyone has any questions, feel free to enter them in the question box. Another question that I had is, this is with regards to the lower extremity, mostly this talk, but is there any major differences when you're talking about manifestations of peripheral artery disease in the upper extremity in terms of
Usually
treatment?
not. Usually not, but the prevalence of upper extremity peripheral arterial disease is significantly less than lower extremities. We rarely, maybe I do end up doing one or two cases a year for upper extremity peripheral arterial disease. Usually like subclavian, and usually it's a patient who has diabetes and renal on dialysis, and then there's a fistula and a graft. Very complicated patients, and they're very rare. But lower extremity is much more common for peripheral arterial disease than the upper extremities, like much higher.
Okay. Another question that we have over here is that when you stent, what anticoagulation medications do you place the patient on and for how long? And does it vary for DES versus a non-drug eluting stent?
That's controversial. In my practice, all the patients they go on Plavix for 3 months, and of course during the procedure, patient is fully anticoagulated with heparin.
Okay. Another question is, what advice would you give a new attending at a fellowship on how to build a peripheral arterial disease practice?
It's very important to close with the vascular surgeon on site. You need to have a collegial relationship with them because they need your help and you will need their help. It's very important to have a multidisciplinary approach to these patients. Go to grand rounds, participate in all their activities, and try to build a unit as a team. It's not going to be a single man show. You need to work with the referring physician, with the internal medicine doctor, with the vascular surgeon, with the podiatrist. Everyone needs to be on board to understand what's the goal for the patient individually. It's not a one size fits all type of approach.
Right. Okay, and just another question. What do you think the next steps are in terms of like future studies with regards to peripheral arterial disease treatment?
I think the drug-eluting stents and balloons, I think they are the biggest ones. I think that's where we need to focus on, and possibly biodegradable stents.
Okay, great. Well, I don't think we have any more questions at this point. So thank you for that. And I just
Thank you
wanted
for
to,
the
I know
opportunity.
actually Dr. Gohari had an emergency case tonight at the hospital, and he still was willing to give the talk and, was very flexible to make it work out. So really a big thank you to you for your
So thank you
time
for
and
organizing it, and thank you for the
educating us.
privilege.
Okay, I guess we'll wrap it up here. Have a great night, everyone.
Good night.